We are delighted to have you all join us for an insightful case discussion on intracerebral hemorrhage. This session promises to be both educational and engaging as we delve deep into the clinical challenges, management approaches, and real world insight surrounding this critical condition. We are truly honored to have with us Dr. Mahadev, consultant intensivist, Manipal Hospital, Mysuru. We look forward to an enriching discussion that enhances our understanding and clinical approach to intracerebral hemorrhage. Without further ado, I now invite Dr. Mahadev to take us through today's case presentation. Over to you, sir. Thank you.
Thank you, Dr. Athira, for introducing me to this program. So, we'll be restricting ourselves for intracranial hemorrhage. Last class, you all would have heard about acute ischemic stroke. Dr. Raghunath has extensively covered the topic. So, we will restrict ourselves to intracranial hemorrhage only. And I will be presenting a case, a small brief presentation. This will be followed by how discussion about the cases. So, thank you all for making me present this case. Okay, here is a 56-year-old man. He is an hypertensive. He was on telmisartan 40 mg once daily. He's a non-diabetic. He was on oral hypoglycemic agents. He has a history of IHT. He underwent plasty. He is put on dual antiplatelets. Now this man is brought to ER with history of right-sided weakness. It was sudden in onset, and patient had a slurring of speech. He had deviation of face to right actually, and all these things has happened since past 1.5 hours. So from the past 1.5 hours, the patient noticed and he was brought to ER with the above history. Whenever such a patient comes, we need to evaluate them. So we need to take a proper history, whether is there any history related to trauma, or what are the medications that the patient is receiving, what are drugs that the patient is on. Is there any history of seizures? Is there? We have to take relevant history in duration, onset, and how the presentation, whether it is progressing, whether the patient improved his symptoms. So all these things are important. So we took this history. There was no history of trauma. Patient was on telmisartan and dual antiplatelets and statin, and there was no seizures. So whenever such a patient comes with altered sensorium, with weakness, we have to rule out stroke mimics. The usual, pardon me, the usual stroke mimics are that at the bedside you can rule out is either hypoglycemia or hyperglycemia. And the lab parameters such as hyponatremia, hypocalcemia, infective parameters, encephalitis, all these things we have to send the screen, and we have to go through the parameters to know whether any stroke mimics are there. So when we connected the monitor, his GRPS was 146. So when we connected the monitor, this patient recorded a BP of 200 by 110 mmHg. Heart rate was 84 per minute. He was breathing at a respiratory rate 24 per minute. Detailed neurological evaluation was done. Higher mental functions. Patient was in altered sensorium. He was not responding to commands. Face showed right human palsy. His GCS was is not opening eyes to even to pain. M4 response was there, and he was not speaking. Right hemiparesis, right upper limb was 1/5, and left lower limb, right lower limb was 2/5 power. Pupils were bilateral reactive, it was equal. So this was the evaluation, CNS evaluation. This other organ system evaluation was unremarkable. So what next? So this is a case presentation, so we want to be little interactive. If anybody is there, would you want to intubate this patient? So is there anybody who wants to intubate this patient, or you want to connect oxygen? for this patient. Because his GCS was low, we intubated this patient and we connected the patient on mechanical ventilation. We started on mechanical ventilation. Why we intubated is to, one is to uh, protect the airway and prevent aspirations and provide oxygenation and adequate ventilation. So we need to keep the head end up and we have to get urgent neuroimaging done. So what is the neuroimaging done? CT brain was done, which showed a intraparenchymal bleed in the capsuloganglionic area. You can see, I don't think the image quality is little bad here, but you can appreciate the bleed. So there was a little early mass effect is seen. So why CT brain in this patient? So what do you think? What is, why not MRI? So any patient we suspect a stroke, we have to get a CT brain because it is quick. We can see if there is a bleed, it is better seen than MRI. So interpretation also is easy. Most of the ear physicians, intensivists can read CT better than MRI. So whenever we suspect stroke, first we have to get a CT done to rule out bleed. But here we did a CT brain, we got bleed is there. So this is patient is a non-hypertensive, his BP was on presentation was high. Even acute ischemic stroke BP can be high, but you don't see bleed there. So here bleed is there, patient is hypertensive history is there and his BP was high. So it could be hypertensive bleed. So what are the common sites? Usual common sites that we notice hypertensive bleed is thalamo-capsuloganglionic area and maybe in the intraparenchymal area in temporal lobe or cerebral lobe, cerebral and occipital lobe. These are the usual areas where hypertensive bleeds are commonly seen. We have to rule out other intracranial bleeds. What other intracranial bleeds? Is it in SAH? Is there any CVT? So CVT usually the history is little more prolonged, and SAH only history they'll have severe headache. So we have to, but on CT there is no other intracranial hemorrhages seen. So what is the mechanism of bleed in hypertensive patients? What is the mechanism why these patients bleed is this because of prolonged duration of hypertension, the vessels develop lipohyalinosis and they'll have microaneurysms developed within the vessels, and these deep penetrating vessels rupture when there is high blood pressures leading on to intracerebral hemorrhages. So there can be evidence of raised intracranial pressure. In this patient also we saw some raised ICP features with some midline shift of around 5 millimeter. So that we have to keep in mind. So laboratory investigations, we have to send for complete blood count. You have to evaluate for coagulation profile, see if there are any coagulation abnormalities there. Other organ functions, kidney functions, liver functions, blood grouping if we need to give blood, ABG to assess oxygenation and ventilation and pH. So all these things we have to get it done. And further ICU management is, as I told you, we intubated this patient. He was breathing was initiated on mechanical ventilation with an aim to maintain normocapnia. Circulation BP target, we aim to maintain a systolic BP of 130 to 150 mmHg. BP was controlled with IV lobetalol boluses with infusion of 5 to 10 mg per hour. We ensured that we don't go into hypertension. Hypertension was avoided during the course. Invasive monitoring for arterial blood pressure is instituted. Central line is instituted. Central line to give all these medications. Arterial line to monitor the blood pressures well so that we don't land in hypotension, or to monitor beat to beat BP. And 6 RDPs were arranged. Then ICP monitor. ICP is what determines the cerebral perfusion pressure. Cerebral perfusion pressure is nothing but mean arterial pressure minus intracranial pressure. So any organ, we have to remember this perfusion pressure is important. Perfusion pressure is nothing but mean arterial pressure minus mean venous pressure, or if it is within the space, that intracompartmental pressure. This is important. The difference is actually the perfusion pressure. Whenever ICP goes down, goes up, or mean arterial pressure comes down, there will be compromisation of CPP, cerebral perfusion pressures. That is why in acute ischemic stroke, you see BP going up, because to maintain the cerebral perfusion pressure. So body tries to maintain perfusion pressure in the ischemic area by increasing the systemic pressures. So our aim should be to maintain this cerebral perfusion pressure within normal limits. Head end has to be elevated so that your venous pressure doesn't go up, which can increase the intracranial pressure. So we have to keep the head end elevated around 30 to 40 degrees. Then sedation, if this patient is, we have intubated this patient, we can safely sedate this patient, sedate and paralyze, so that the cerebral oxygen requirements also fall. And we have to institute immediate osmotherapy. What are the options that are available? Can anybody tell me what are the options available for osmotic therapy in this patient? What are the routine osmotic agents that we use? So we use uh, hypertonic saline, that is 3% saline, and mannitol. So is there any difference between or advantage of one over the other, or any superiority of one over? The studies have shown that neither hypertonic saline nor mannitol is found to be superior. But there are few advantages and disadvantages. For example, mannitol is nephrotoxic, relatively nephrotoxic. We avoid it if the creatinine is high. Whereas hypertonic saline has too much of chloride, it can cause normal anion gap metabolic acidosis. So all these things are there. We need to keep it in mind. If the patient is already hypernatremic, then we don't give too much of 3% saline. We try to manage with mannitol. But we need to know that the serum osmolarity, if we maintain, we have to maintain between 310 to 320. Beyond that, it may not be that much helpful. So we have to ensure that seizures do not happen. If there is any seizures, it will likely to increase the oxygen demand, and it will likely to worsen the neurological outcome in this patient. So we have to prevent seizures. We have to control the temperature, because we know every degree rise in temperature, the oxygen requirement goes up by 10% for the tissue level. So reducing the temperature or controlling the temperature will improve the neurological outcome. And sugar control, we have known that even hypoglycemia or hyperglycemia are sudden fluctuations, even within normal range. If it is like 70 to 170, it keeps on fluctuating, then comes to 70, 60. The sudden fluctuations, hypoglycemia, hyperglycemia, all these are found to be dangerous for the neurological outcome. So we have to control sugars, stabilize the sugars, and we need to do ICP monitoring. Nowadays, nobody does invasive ICP monitoring. It is the non-invasive ICP monitoring that has to be instituted. So these are all the ICU care that we have to follow. And whenever we know that this patient has an intracranial bleed, family has to be updated. They have to be detailed discussion has to be done regarding the further course of the disease, further treatment anticipated, and we have to tell what is the possible outcome the patient is likely to have. So all these things has to be detailed, it has to be communicated to the family in detail, and all the relevant documentation has to be done. And we have to take an urgent neurosurgical consultation. This is a neurosurgical emergency. We have to take an urgent neurosurgical consultation. You have to plan for surgical intervention. You have to keep blood and blood products ready, OT ready, anesthetist to be pulled into the loop, stroke team. So all these things, whenever we suspect stroke, before we move on to take the patient for imaging, the stroke team has to be alerted. Then you have to plan surgical decompression for this patient. because he's showing early signs of mass effect and midline shift. So we have to plan surgical decompression. So worsening neurological status with mass effect, we had to take him for a surgical decompression. We can see decompressed brain with the bleed. This patient further course on day 3, patient was tracheostomized. He started slowly improving GCS, M5, and then slowly it started to turn around. Patient was done a tracheostomy on day 4. He was weaned off ventilator to TPs. Patient developed fever spikes. Antibiotics were escalated. And then we sent the culture. On day 8, we had Klebsiella MDR. He had acquired hospital acquired infection. So we had to start MDR protocol, antibiotics. And then day 13, he was discharged from ICU. He was E3, M6, and VT. And day 19, he was discharged from hospital to rehabilitation. So this was the further course that the patient had. So, any doubts till now? Then we move on to discussion, case discussion. So, if there are no doubts, we'll move on to case discussion. Stroke, it is the third leading cause of death, and it is the most important cause which can lead on to disability. So, we have to be, such is the high incidence. So, we have to be very careful when we suspect stroke. And time is brain. We have to act fast. So the usual problems are acute ischemic stroke, subarachnoid hemorrhage, intraparenchymal bleed. These are bleeds which are non-traumatic. So ICH, now we are discussing about intracranial hemorrhage. Most of the times intraparenchymal bleeds are referred to as hemorrhage. So what has happened is acute ischemic stroke. Last class, you would have seen you would have heard Dr. Raghunath talking about acute ischemic stroke, AIS, sorry, it is written as AIH. AIS, acute ischemic stroke, there is tremendous development has happened over last 2 decades. So we have gone into era of thrombolysis. So we are trying to extend the window period for thrombolysis. We have gone into endovascular interventions. So mechanical thrombectomies. So we are trying to extend the indications timeline for 24 hours for mechanical thrombectomy. So much has progressed in acute ischemic stroke, but not much has progressed in acute cerebral intracranial hemorrhage. So we have to be vigilant on identifying this, and time is very important, very crucial in treating and instituting treatment protocols for these patients. We will deal with what is the timelines that we have to follow. So when we come to talk about stroke, stroke is broadly into acute ischemic stroke and intracranial hemorrhages. Now I will be restricting my this thing to intracranial hemorrhages. Intracranial hemorrhages, the usual incidence among the stroke is 10 to 15%, whereas 85 to 90% is acute ischemic stroke. The mortality in ICH is 30 to 40%. They die within 1 month. 30 to 40% of the patients die. Whereas in acute ischemic stroke, only 10 to 15% die in 1 month. And ICH, usually the presentation is sudden, and they want progress over time, usually. Whereas in stroke, the stroke, they will be presenting suddenly, but they may progress over minutes to hours. And sometimes they can be fluctuating course also. Sometimes it will improve, limb movements can improve and then go. Or there can be sudden onset, then they can continue to little improvement can happen. Earlier we used to refer it as transient ischemic attack, where they used to completely recover within 24 hours. So the mode of pathogenesis in ICH is lipohyalinosis of the vessels, whereas in acute ischemic stroke, it is atherosclerosis of the arteries. So these are the broader differences between these two problems. I hope everybody is following this. So if there is any doubt in the presentation, you can interrupt me and feel free to ask. So further management, whenever we have an intracranial hemorrhage, it leads to primary injury. This is the primary injury. So we need to, our aim should be to minimize the primary injury. So we should restrict the size of the hematoma. We should ensure that it doesn't increase. This primary injury leads on to inflammatory response, which can cause secondary injury. We need to prevent secondary injury from happening. This further leads to edema and increased ICP, which can cause tertiary injury and deterioration of neurological conditions. So we need to remember 1/3 of patients increase their hematoma size in first 3 hours. So we have to act fast. Within 3 hours of the onset of symptoms, we have to ensure that patient doesn't deteriorate. So hypertension and anticoagulation therapy, they increase the risk of patients' size of the hematoma increasing. So we have to be vigilant on these important things. So whenever we get a patient with ICH, there will be increase in blood pressure. Even in acute ischemic stroke also, the blood pressure goes up. So we need to, our aim should be to whether the patient is hypertensive or normotensive, BP can go up. So our aim should be to restrict the BP. And if the BP is high, we need to bring it down. BP control should be as soon as possible. Interact 3 trial, which was published in 2023, showed a bundled approach with BP, glucose, and temperature control with rapid reversal of anticoagulation. So these 4 bundles approach has shown to be having a better outcome for the patient. So our goal should be to within 1 hour, first hour, to get the BP to 130 to 150. But ensure that you don't bring down the BP more than 60 mmHg systolic. So don't bring down more than 60 systolic within 1 hour. So target to less than, try to get the BP around 60 mmHg, or if possible, if it is around 200, you can get it down to 130 to 150 mmHg. And if the patient has INR of more than 1.3 and patient might be on anticoagulation, we have to give vitamin K and 4-factor PCC to get the INR within 1.3. So door to anticoagulation reversal time should be less than 1 hour. So 1 hour is very crucial when we get this patient. We have to get the BP under control. If the patient is on, if the coagulation is a problem, we have to reverse it and get it to normalize it within 60 minutes. This is very important. So because we don't have much to do intervene, we have to take care of these patients so that patient doesn't progress, his hematoma doesn't worsen, and neurological outcome will be better for this patient. So how do we, now we talked about BP and coagulopathy. If the patient is on warfarin or acetrom, we have to give vitamin K and give FFP or 4-factor PCC. So all these things can be given. If the patient is on direct oral anticoagulants, for example, if the patient is dabigatran, you can give idarucizumab, which is provided by the company itself. You can ask them and arrange as soon as possible and give it. If the patient is having apixaban or rivaroxaban, then the antagonist is endaxanate alpha. We had a patient where he was taking rivaroxaban and he had bled. So we tried to get this endaxanate alpha. It is not available still in India. So we had to give only 4-factor PCC and cryoprecipitate for that patient. But patient, despite that, he continued to worsen and then he died. So we can give cryoprecipitate 4-factor PCC also can be given in these patients. Remember the dose is around, you can give 10 to 50 units per kg. That is the dose for 4-factor PCC. Antiplatelets, if the patient is on antiplatelets, you can give reverse it with RDP, or if there is time, we can arrange SDP. So once we correct coagulopathy, then we have to move on to achieving hemostasis so that there is no progression. So there are few pharmacological drugs like factor 7A. The studies have shown there is no mortality benefit when we use factor 7A, activated factor 7. So tranexamic acid have been also been used, but in non-traumatic patients, no benefit has been shown. So surgical evacuation is the next modality of treatment. Stitch to trial has shown reduced mortality with surgical evacuation, but it is mortality reduction is not statistically significant. So that was about stitch to trial. The most important is we have to, as we discussed with Interact 3 trials, acute care bundle. We have to maintain BP control. We have to reverse anticoagulation, glucose and temperature control. All these things are as a bundle. We as intensivists are very familiar with bundle. Bundle is if we do all these things together, the outcome is much more than when we institute them separately. So if we do all these things together, the neurological outcome is found to be better. And that has been shown in Interact 3 trial. So we have to ensure that these things are happening. So these are the timelines that we have to be careful about. So whenever we get the patient, we have to ensure that the door to doctor time, the doctor has to, these patients have to be attended by a doctor within 10 minutes of their arrival into ER, and stroke team has to be alerted, and one person from the stroke team has to be seeing them within 15 minutes, and door to CT time should be not more than 25 minutes. Within 25 minutes the CT should be there, and within 45 minutes the specialist should read the CT and take necessary actions. By the time we would have drawn the laboratory results, and within 45 minutes the laboratory results have to be read, and we have to institute anticoagulation reversal within 60 minutes. That is the timeline. And if there is a necessity to evacuate the hematoma, it has to be done within 3 hours. 90 to 180 minutes is the timeline that has been suggested. So what are the complications? So complications can there can be worsening hematoma that which can lead on to herniations, which can lead on to infarctions, poor neurological outcome. Patient can have hydrocephalus, coning, and death can happen. Systemic patient can be on ventilator. We can develop ventilator-associated infections, ventilator-induced lung injuries, DVT, pulmonary embolism, acute kidney injury, hospital-acquired infections, metabolic complications, SIADH, diabetes insipidus, salt wasting syndrome. So all these things can develop, and patient can have brain death also. So prognosis, the most important prognostic parameters is GCS on arrival, which shows the extent of the disease, and hematoma volume and compression of the opposite side. So this also tells about the more the volume, bad is the prognosis. Brainstem involvement, if brainstem involvement is there, then the prognosis is bad. Timely intervention to prevent secondary hemorrhage is very important. As we discussed, we have to stick to our timelines. Despite all that, in a larger bleed, the mortality is 30 to 40% has been discussed. So to conclude, intracerebral hemorrhage is a neurological emergency. We need to have multifaceted approach. Stroke team, as it would be discussed in the earlier classes. Acute intracranial hemorrhage care bundle has to be within in place, especially after the Interact 3 trials. We know that care bundle will improve the outcome. Time-based rapid interventions is very important. We have to be vigilant on time. So we need to audit ourselves, evaluate and improve our timings, our response for better mortality, better morbidity, and for better functional outcome from intracranial hemorrhage. So this is the last slide. Any discussions? We're happy to take questions. So anything else? Anything? Anybody want to add or any other inputs? Welcome. I'm seeing through the chats box. Nothing much is there. Anything is there? I'm happy to discuss. Dr. Atira, Dr. Raghunath, anything to add on?
No, Mahadev, it was very elaborative talk, and I think students got the information. Any questions? Anyone
Any
want to
questions?
discuss?
Yeah, please let us know. Happy to take questions.
Yes, sir. I want to ask a question regarding how to decide when to choose mannitol and 3% saline.
You can go with either of them, doctor. It is all institutional protocol. And if the mass effect is more and if the time is there, we usually start both sometimes. We give 6 hourly or overlapping every 3 hourly, either mannitol or 3% saline comes.
Because in my institution, they most of the time we use mannitol.
And
They
if the
don't
patient,
uh, they
yeah,
don't use 3% saline. So I just want to be know on which cases I should go for
if you
3%
are
saline.
3% saline is usually chosen if the patient has acute kidney injury. We avoid
Mm-hmm.
mannitol and give 3% saline. And studies have shown that there is no uh, advantage of one over the other. So you can use either of them.
Either of them.
Yeah.
Thank you, sir.
Any other questions? Somebody in the chat box. Sir, target temperature. Dr. Richard is asking target temperature.
Temperature, there is no target temperature. You have to maintain euthermia. That means if the patient has a high temperature, you have to aggressively treat. If the patient has fever, bring down the temperature to normothermia. So temperature, seizures, all this increase the cerebral oxygen metabolic rate. So ICP will go up. So we have to reduce the cerebral requirement of oxygen. So that is why we have to control seizures. We have to give control temperature, sedate and paralyze the patient so that his ICP can be easily managed initially.
Dr. Karthik Menon. Sir, when we keep a patient with IC bleed for monitoring and looking for worsening of symptoms, when is the appropriate time for surgery? If worsening and what we should check, ideal time and ideal. Okay, that is the question from Karthik Menon.
Yeah, Dr. Karthik, if there is a worsening of neurological signs, like if there is a motor response is coming down, or if the pupils start to dilate, if there is pressure effects on CT, then you have to take the patient in and decompress the patient. Sometimes patient may present with all these features, then we will have to offer surgery for the patient. Surgical decompression has to be done. As we discussed, if there is signs of raised ICP and the mass effect, then you have to take the patient and decompress within 3 hours. That is the recommendation. So
Okay.
if nothing else, then
Ideal time for extubation, Dr. Richard is asking. Ideal time for
there
extubation.
is nothing like ideal time for extubation. If the patient is conscious, neurologically stable, is not worsening, then you can extubate. Usually, most of the patients will not be so alert and bright. Then we'll have to tracheostomize and gradually wean them off from ventilator. See, as long as the patient is undergoing like vigorous therapy to maintain intracranial cerebral perfusion pressure, that is to control ICP and all, we ventilate the patient. When we say that the patient has stabilized, there is no much increase in either bleed or edema on repeat scans, then we start tapering them off ventilator.
Okay, Richard.
Any other questions?
In case of intracerebral hemorrhage, the moment the patient comes, most important is management of BP. So if you're not maintaining BP, then there is a chance of increase in the bleed and patient may deteriorate. That is the important point. And even while intubating, while ventilating, make sure BP is not improving. And anytime GCS worsening, then go for early surgery. Decompressive connectomy definitely save many patients.
Dr.
Dr. Vishna.
Salman has asked, is there any requirement for EVD drain? See, this patient intraparenchymal bleed without ventricular bleed. Then we usually don't put a EVD. We go for decompression. If there is an intraventricular bleed, you can put EVD and drain the EVD so that the pressures come down. And if there is any evidence of hydrocephalus, then EVD can be inserted. Usually, if the patient has an intraventricular bleed, there is chance of patient going in for hydrocephalus, obstructive hydrocephalus.
Yeah, while managing EVD also, if there is ICP monitoring is there, then it is good, because the moment you put EVD, the intracranial pressure reduces, bleed may start increasing because of the tamponade effect is gone. So you should make sure that you are maintaining slightly higher ICP while when you put EVD. Once you done surgery, decompressive craniotomy, then you maintain the normal ICP pressure with EVD. And EVD maintenance also, there is a techniques are there. You should know, like you do ventricular associated bundle, VAP bundles are there, central line CRBSI bundles are there, central line bundles. Like that, they have catheter bundles, EVD bundles also there. Please read that EVD bundles, how to take care of the EVD. That is very important to prevent infection. So somebody asking,
hello, ಒಂದು ನಿಮಿಷ ಮಾಡ್ತೀನಿ.
Vishna, sir, how long 3% normal saline or mannitol can be used as an anterior measure if you are managing patient conservatively? Dr. Mahadev.
Okay, sorry, I missed it.
How
Sir,
long
3% saline or a mannitol can be used for as an anti-edema measures? See, as long as the patient has signs of raised ICP, we have to continue antihypertensive therapy. Anti-raised intracranial pressure measures has to be continued. When the patient stabilizes, when there is clinical improvement, and imaging also shows there is reduction in the mass effect or edema, then we can start tapering these medications. So there is no definite like timeline. We have to stop here or we have to start there, like that. So it depends on the patient condition.
Correct. I want to add one point, Dr. Mahadev. Mannitol, many of us using mannitol, like TID dose, QID dose. So what is the message I want to say is, if the patient is deteriorating in front of you, if patient is coming with ICH, an increase in ICP or intracranial pressure signs are there, give bolus like a 3 or 4 bottles of mannitol. Usually we give 1 bottle of mannitol, that is 20%. That is not sufficient for the patient. Usually we give 1 to 2 milligram per kg, that is a dose. So usually requirement will be 3 to 4 bottles of mannitol. And if patient mannitol should be given need basis. Okay, usually they use 8th hourly and 6th hourly dose. That is not the ideal way. You should give boluses and see the response. And again, if your ICP monitoring is there, look at the ICP monitoring and give boluses accordingly. because most of the institution won't do ICP monitoring. They use the technique of maintain like a 6th hourly or 8th hourly, and they will taper the dose. Actually, should be given need basis mannitol. When 3% NaCl also, we can give boluses like a 100 ml, 200 ml. We can give boluses. Even 3% NaCl, 7.5% NaCl should be given hypotonic salines. Even boluses. What usually institution follow is, because they don't have ICP monitoring, they give infusion to target sodium higher side. Actually we want to measure the osmolality. We are not able to measure, so we calculate that 2 into sodium. So if sodium, if we maintain around 150, so osmolality around 300. So we want to maintain around 300. Normal will be 280. So we maintain around 300, above 300, so that it acts as a hyperosmolar therapy. So that is what 3% given as an infusion. So make sure that when need is not there, try to stop mannitol, because it harms basically kidney injury and all. So one more question is there, Madhav.
Is there any role of dexamethasone? This is a patient with non-traumatic bleed. Even traumatic bleed also, there is no role of, clearly no role of steroid. Steroid is only given in patients with tumors for tumor-associated edema. Otherwise, steroid has no role.
Yeah. Steroid, very good question. Somebody asking. Definitely, steroid has no role. Even in trauma, people use steroids. There is a big trial, very big trial is there, which is done very early, many years back. Clearly shown it increase the mortality. Don't use steroid for the trauma or ICH patients. Another question we missed, Dr. Salman. When we go for non-invasive ICP monitoring or invasive monitoring, when you go for non-invasive or invasive?
Non-invasive monitoring can be done anytime. So if you're well versed with optic nerve sheath diameter monitoring, so what you have to do is you put your ultrasound probe and 3 millimeter behind the globe. If the size of the optic nerve sheath is more than 5 millimeter, that correlates to ICP of 20 roughly. So if the size of the optic nerve sheath 3 millimeter behind the globe is more than 5 millimeter, it says that ICP is more than 20. Other thing is you can go for transcranial Doppler with a pulsatility index. So all these things you have to have a little training to do. And if you can do, there is nothing like when we have to go, you can start doing it. Only thing is don't press the eye too much. Gentle pressure on the eye, and we have to do this. So invasive, as I told you, there is no role of invasive monitoring now. Because of risk of infection. We don't transduce, even if we have intraventricular catheter is there, we don't transduce it to the transducer and monitor it because of risk of infection. Nobody is now doing invasive monitoring. It's non-invasive monitoring. It can be instituted anytime.
Okay. Okay, very good interaction today. Good questions actually. So is there any other questions? Dr. Madhav, you want to tell anything?
Yeah, nothing much. I think we have covered intraparenchymal or intracranial hemorrhages. So we'll move on to next topic coming days.
Thank you, Dr. Madhav. Atira? Yeah.
Thank you, sir. We are so grateful for the time and effort you put into sharing your knowledge with our audience. Thank you so much, sir.
Thank you. Thank you.
Thank you, sir. Thank you all for attending our webinar. We hope you found the insights on this topic valuable. Your all participation made the session engaging. Thank you all.
Thank you.
Thank you.
Thank you, sir.